Assalamu alaikum. I am Professor Hisham Hamad from Tanta University, Egypt. I'm going to speak about vestibular function and cochlear implantation. My objective here is to provide comprehensive review of the vestibular function in CI patients, preoperatively, intraoperatively, and postoperatively, and to provide an algorithm for diagnosis and management of vestibular deficiency in CI patients, and also to provide suggestions to modify the protocol of candidacy selection implemented by the medical insurance as the main provider of the service in Egypt. Basics. Of course, we all know that balance is controlled by integrating sensory output from the vestibular system, from the eyes, the visual system, and from proprioceptive receptors in the joints, muscle of the neck, trunk, and legs. Recently, sound perception by the cochlea was found to have a role in balance controlling. Deficient sensory input from the vestibular end organs can be partially compensated by two ways: either centrally by suppressing the more active labyrinth so that the post labyrinth will work in the same level, or on relying on other sensory input. Mostly in these cases will be vision and proprioception. Recently, auditory input from the cochlea, which is found to play a minor role in balance control in ordinary condition, but it gains more importance when the vestibular loss is severe. This is a slide from Medel showing that how the single-sided deafness orient himself in the space when his hearing was one ear only. It seems that things present on the deaf side or near the midline will be mispositioned to the non-deaf side, disturbing the sensation of the body in space. Actually, hearing has some effect on balance. There is also many publications have been presented during the last years about the beneficial effect of hearing aid and the cochlear implant on balance awareness. Probably this is why falling in the elderly patient was reported to be less after using of the hearing aid or UCI. Actually, falling was found to be the main cause of death in the elderly. Also, falling was found to have a significant cause of device failure in children. Effect of vestibular function on the implant performance. It was found that there is a risk ratio of CI failure in patients with bilateral areflexia, and was found this risk ratio reach up to 90%. 90% of patients who's having bilateral areflexia will have failure of their implant in the future. Also, some studies, including this one from Japan, showed a positive correlation between the pre-operative vestibular function and the post-operative speech recognition. This study from Japan suggested that the original cochlear disorder capable of destroying both the cochlea and the vestibular function concomitantly are considered so severe so that they can also produce massive destruction of the ganglion cell, resulting in poor post-operative speech recognition in implanted patient. So it seems there is a correlation between the preoperative vestibular function and the postoperative consonant recognition. So the degree of the residual vestibular function preoperatively seems to be one of the factors influencing the postoperative speech development in cochlear implant patient. Preoperative vestibular function in cochlear implanted patient. Due to anatomical proximity of the cochlea and the vestibular system, pathologies causing hearing loss are expected to affect also the vestibular system as well. Actually, 70% of the children have concurrent vestibular dysfunction, and 40% have complete areflexia. So, bilateral vestibular loss is actually as common as bilateral sensorineural hearing loss, but only clinician miss the diagnosis because he interested only into the sensorineural hearing loss, and because kids don't complain of vertigo if vestibular loss is non-progressive, congenital, or bilateral. Many etiologies of hearing loss are known to have high possibility of vestibular loss as well. For example, in meningitis, there is 100% vestibular loss. When in all cases of inner ear malformation, there is a 50% of vestibular loss. In cytomegalic virus is known to produce about 90% vestibular loss. And also syndromic hearing loss, like Usher syndrome, patient type 1, they have 100% vestibular loss. Charge syndrome, there is near total vestibular loss. Also, Waardenburg syndrome, Brennan syndrome, autoimmune inner disease, and auditory neuropathy spectrum disorder, all these were found to have high possibility of vestibular loss as well as the sensorineural hearing loss. Can radiology predict vestibular function? Yes, in sometimes. A correlation was found between the lateral semialveolar canal fibrosis on MRI and the abnormal caloric response. Also, there is another correlation between the malignant appearance of the cochlea due to posterior labyrinth aplasia and charge syndrome with the presence of the near total vestibular loss in this patient. Why should we bother about vestibular function in children with sensorineural hearing loss? Because it is common as the sensorineural hearing loss itself. Because it has some consequences beyond the balance. It can affect the implant success. It bothers the patient. It can teach us how to do compensation for this patient. And because falls in cochlear implantation matter, it may result in device failure, and even it matters for the patient. It can lead to fractures and maybe life endangering for elderly patients. A positive correlation was found between the absence of the vestibular function, a significant correlation between the absence of the vestibular function and the failure of the implant. So, it is advisable to assess the vestibular function in all patients scheduled for cochlear implantation in order to define a baseline for future reference and for early diagnosis of syndromes which has no skeletal abnormalities like Usher syndrome, and also in selecting the site we want to implant. The ear with the poor vestibular function should be chosen for surgery in unilateral cochlear implantation if there is no other contraindication. Also, it is advisable to assess the vestibular function in all patients scheduled for cochlear implantation because this patient has to be counseled about the risk of post-operative vestibular loss. Actually, in unilateral cochlear implantation, the risk is about 30% deterioration of the vestibular function, and some about 70% of these patients will have total areflexia in the implanted site. Also, in bilateral cochlear implantation, the total vestibular loss is about 4% bilaterally, and also on bilateral cochlear implantation, if the preoperative vestibular function is normal. So we suggest doing simultaneous bilateral implantation only if the child is walking. But if the child is not walking yet, so it is better to do sequential implantation with vestibular re-evaluation after the first implant if the child is not walking yet. Vestibular function assessment. Two methods to study vestibular function, either objectively by testing the vestibular end organ individually by like caloric test, CVIMB, ocular VIMB, and VHIT. All tests should be done, and there is no single test that can specify the site and the magnitude of the deficit, the vestibular deficit. Or by testing the overall performance using clinical balance tests. It can also, vestibular function can be assessed subjectively by the Deafness Handicap Inventory Questionnaire. Preoperative testing of the vestibular function is recommended. However, proper testing is expensive, time-consuming, difficult, or maybe impossible to do in some children, may be not cost-effective. So we suggest to better perform it on case-by-case basis based on the finding of the cause of deafness, the preoperative symptoms, if the patient has dizziness, history of past vestibular insult, cases of bilateral cochlear implantation, and by screening tests for vestibular function. Simple and reliable screening tests for vestibular function in children are to ask about the age of the motor milestones development. Children, upper limit, who fail to control their head beyond the 4 months, we should be suspected of having significant vestibular loss. Also, if they are not unable to sit after the age of 9 months or unable to work after 18 months, all these suggestive of the presence of significant vestibular loss. We can do head thrust testing. It's easy to do it in children, and we can do one leg standing testing with the eyes open and the eyes closed. Actually, it has been found to be have a sensitivity of about 90% sensitivity and 85% specificity for the presence of vestibular function deficiency. Elder children can do both the two tests, measuring balance by using the balance subset, by asking them to stand with 1 feet apart on a line, walking forward on a line, standing on one leg on a line, walking forward heel to toe on a line, standing on one leg on a balance beam, or standing heel to toe on a balance beam. It gives reliable and objective results. Intraoperative factors affecting the vestibular function in cochlear implant patient. Surgical technique. The round window was reported to produce less deterioration than cochleostomy. But the most important factor is strict scala tympani insertion is important. No deviation to the scala vestibuli. But the insertion depth is not correlated, especially when you are using flexible electrode. Electrode insertion speed is very important. The slower, the better the preservation of the vestibular function. Electrode type The device type according to company does not differ, but straight electrode were found to cause significant reduction in the vestibular function compared to flexible electrode, as they may cause persistent pressure on the lateral wall, resulting in late rupture of the membrane. Age, it matters. Children can compensate better. Preoperative vestibular function, the cause of deafness by self, it is not, but the presence of preoperative vestibular is important. So hearing preservation technique through the round window and using soft electrode is advisable in all cases of CI surgery, even in the presence of total or profound hearing loss, aiming at preservation of the residual vestibular function as well as the residual cochlear function. Post-operative vestibular function. Generally, CI has a negative effect on the vestibular function with an adverse risk of 30% post-CI deterioration, 7% post-CI areflexia, total loss of the function, and 4% bilateral total vestibular loss in bilateral CI patient. The deterioration affects mainly the saccule, followed by the utricle, and then the lateral semicircular canal. However, many reported a big discrepancy in the incidence of various post-operative vestibular tests deterioration, ranging from 0 to 95%. There was found to 85% deterioration of the CVIMP, 75% deterioration also the CVIMP by outer author, 35% deterioration in the OVIMP, 50% caloric test deterioration in cochleostomy patient, and 90% caloric test deterioration in round window approach. There is a poor correlation between the objective vestibular test results and the subjective symptoms by the patient. Many have vestibular function degradation after CI surgery, but no vestibular symptoms. On the other hand, some may suffer from post-CI vertigo, but with normal caloric test and VIMP. So this may be explained by the limited involvement of the utricle, or by the electrophysiological current spread from the cochlea to the vestibule causing vertigo. The most possible factors causing post-operative vertigo are labyrinthial irritation, serous labyrinthitis, from irritation by foreign body, blood, bone dusts, or electrode itself, or intraoperative perilymph leak, if you are not seal the electrode completely, or post-operative perilymph leak if our sealing for the cochleostomy or the round window has failed. Pressure transient trauma, because we inserted the electrode rapidly, a tsunami wave of perilymph occurs, which causes direct otolith organ damage, or due to the mixing of the endolymph with the perilymph when the basilar membrane ruptures. Moreover, there are cases where otoconia have been apparently dislocated as a result of intraoperative drilling or electric current spread during CI activation with consequent benign paroxysmal positional vertigo. Less directly, after the implantation, other persistent vestibular conditions such as fibrosis, obliteration of the inner ear, endolymphatic hydrops, disturbance of the inner ear homeostasis, and lastly, electric co-stimulation of the vestibular fibers when the implant is on. How to manage? Post-surgery, clinically patient may complain of transient vertigo, in about range, some reported at 0.5%, some reported 75%, and this is due to reactive serous labyrinthines. But severe prolonged vertigo immediately post-operative, in these cases we have to exclude post-operative perilymph fistula, which may need force us to return the patient to the operating theater and try to close the fistula. In these cases, we have to prevent oral intake for the patient, and we have to do CT scan to confirm the electrode position after exclusion of the perilymph fistula, of course, or investigate for severe vestibular loss, because if there is bilateral vestibular loss. In these cases, we have to arrange for vestibular rehab. But if the severe prolonged vertigo occurs late and persists after surgery, so in these cases we have to do CT to exclude the late electrode migration. The electrode may migrate from the cochlea to the vestibular system. And also we have to investigate for severe vestibular loss, because if there is severe bilateral severe vestibular loss due to possible drop out of the vestibular function at a later age, and arrange for visceral rehab. Vertigo during device activation, we have to suspect vestibular malpositioning and do CT. But delayed recurrent episodic vertigo may be due to Meniere's disease or benign positional vertigo, and we have to treat as standards. The question now, can CI surgery improve vestibular function? The answer is yes. In some patients with bilateral severe or total vestibular loss preoperatively were reported to have improved balance in one leg standing and the both two, and less swaying from with CI device on than off. Also, Ramos was able to record electric vamp after CI surgery in patient with absence vamp preoperatively. This improvement was not found to be related to the presence or absence of the sound, but was found to be related to the CI device on or off. The positive effect here, you can see the positive effect on the vestibular of the CI on the vestibular function can be explained on the hypothesis that sound can compensate for deficient vestibular sensory input, improving balance when there is severe preoperative vestibular loss. Also, electric co-stimulation of the vestibule by the cochlear implant. So actually here the cochlear implant is acting as a vestibular implant as well. To conclude, preoperative vestibular dysfunction is common, up to 70% in CI children or patients. It is advisable to screen for vestibular function before CI surgery. This helps in selecting which ear for surgery in unilateral CI, choice for simultaneous or sequential surgery in bilateral CI, early diagnosis of Usher syndrome 1. A clinical screening for vestibular function is easy and reliable, depending on asking about the milestone development for infant and younger children, doing one leg standing test with eyes open and closed, and for older children we do both two tests. Patient failing the screening test should be sent for more sophisticated vestibular function test and eye examination. Also, there is a 30% risk of post-operative deterioration of the vestibular function after CI surgery, but generally it does not produce symptoms in most children. There is a risk of post-operative vestibular deterioration vestibular deterioration can be minimized but not eliminated by doing hearing preservation soft surgery, using soft electrode, using a steroid, micro opening of the round window, using round window technique, and by slow insertion of the flexible electrode strictly in the scala tympani. Few patients with severe or total bilateral vestibular loss preoperatively may experience improved balance after and the recording of the electric VIMB after CI surgery. And thank you so much.